I'm Melisa Idris. Welcome to The Future is Female. This is the show where we find the extraordinary in every woman. I'm delighted to introduce my guest today, consultant cardiologist Dr Norazlina Mohd Yusof. She's the clinical lead for cardiology services at Prince Court Medical Centre. Welcome to the show, Dr. Norazlina. Thank you so much for joining me.
Thank you for having me.
It's lovely. You're the first cardiologist I'm interviewing on the show, and I'm very curious to learn a little bit more about your journey to becoming a cardiologist and how that eventually led you to be the clinical lead for cardiology services.
I was born in Kuala Lumpur and attended the Mara Junior Science College in Kota Baru. And then on, I got a scholarship to study in Australia. But 2 years later, my father was diagnosed with terminal cancer, so I came back to Malaysia and continued in the University Kebangsaan Malaysia in Malaysia. And when I was a house officer, I was offered to join the Young Lecturer Scheme doing the Master's Program for Internal Medicine, which I accepted, of course. And I did my Master's in 3 years. And when I completed my Master's, I was then offered a postgraduate training scholarship to go to the UK. And in 2008, I came back with my family to join Prince Court, and I've been there ever since. I'm now the current head of medicine and the lead of cardiology in the hospital. So
tell me, is cardiology a male-dominated field? Are there a lot of women in this field? Is it gender balanced?
Well, it is very much a male-dominated field. In fact, real-world data shows that less than 15% of cardiologists worldwide, that's 1/5, less than 15% of cardiologists worldwide are women.
Wow.
Yes.
Why do you think there are so few women in cardiology? Is it worse in the subspecialties?
Well, particularly in cardiology, I would think. And the reason for that is because the training is very tough. It requires long hours. And sometimes when when women at that age, when they're going for postgraduate training, they are in their reproductive age group, so they want to have families, and obviously when you have long hours and late nights, it's not very conducive to to the family. So a lot of female doctors opt not to do cardiology for that very reason. In fact, when you look at the medical graduates, most medical schools, most medical graduates are actually women. But the ratio about 60/40. But however, those actually complete postgraduate training are mainly men, and even less so women actually do training in cardiology, as I mentioned earlier. And the other reason that you tend to see less women, I think, is also because of gender discrimination, which is still ongoing even now. In fact, in the States, there was a report recently that 66% of cardiologists, female cardiologists, have actually been exposed to gender discrimination, especially with regards to childcare, schooling, as opposed to 22% of male colleagues. And therefore, it's very important to try to to address this gender discrimination.
So those are quite shocking statistics. Can I just ask you, how do we think about that? What would be the consequences or the implications of not having the kind of diversity, gender diversity that we hope to see in the profession of cardiology? Where do you see the impact of it being a male-dominated field?
Well, the thing is, and that's a very good question. The thing is that a lot of women do not know that the #1 killer for women is actually heart disease. Most people tend to think that this cardiac disease, a heart disease, is actually a disease of men. Actually, it kills more women than men around the world.
Really?
Yes. In fact, every year, 2.4 million of women die compared to 2.1 million of men. And therefore, having female cardiologists is actually very important because because it's very much a disease of our own gender. And the other thing as well, and the reason why women tend to suffer most from heart disease is that the symptoms that they present with is always atypical. For example, men tend to present with pain in the chest, whereas women tend to present with atypical symptoms, for example, pain in the jaw, or pain in the back, or pain in the tummy. It's often misdiagnosed as postmenopausal symptoms. And because of that, they're often presented late to the cardiologist, and therefore the treatment therefore becomes delayed as well,
Okay.
and hence therefore they don't do as well.
So talk to me a little bit about how gender influences the presentation and then the management of cardiovascular diseases. When you say that it presents differently in women and men, are doctors trained to recognize the different presentations of the disease and therefore can diagnose quickly and provide treatment? Is treatment the same for men and women? Maybe you can give us a little bit of an overview.
Well, the thing is, I mean, perhaps to a junior doctor, the symptoms of epigastric pain, normally, you know, they would pass it off as gastritis. But obviously, you know, if the pain does not dissipate, or the pain gets worse, then it obviously would trigger that it's probably not just a plain gastritis. Now, but because of the delay in treatment, and partly because as well, there was a very big clinical trial that was actually done about 5 or 6 years ago, which showed that women, when they are diagnosed with heart disease and when they are presented to the cardiological teams, they do not appear to get the same treatment that men tend to get. In other words, they're normally not offered coronary angiography as a male patient would be offered. And hence, therefore, this difference in the management, unfortunately, gives rise to the mortality rates around the world, which is higher in women. Hence, therefore, the statistics of the increase in death numbers amongst female patients.
Is it changing now? Are you seeing things change?
Well, I think it's getting better,
Okay.
partly because there's more and more a movement now to actually create awareness amongst female patients. In fact, in all the cardiological symposiums that's going on around the world very frequently, that we actually have a dedicated symposium for women and heart disease, particularly to address this problem, you know, to create more awareness amongst doctors, amongst young cardiologists as well, to be wary of heart disease in women, because it is the #1 killer for women. In fact, for every 4 ladies who might die of cancer, actually 8 who have died from heart disease.
Wow, wow. How do we, I want to come back to the question about how do we address the fact that it is the #1 killer for women. But I do want to ask you a little bit more about about women and heart health. And how menopause comes into play with that. How does menopause affect women's cardiovascular health?
Well, when a woman reaches menopause, which is by definition absence of periods for 1 year, then the hormonal changes, estrogen in particular, will start to dwindle down. Now, estrogen does confer a degree of protection with regards to blood pressure and cholesterol. However, when estrogen levels dwindle down, then you notice that the blood pressure and cholesterol levels in this woman tend to go up. In fact, it's during this particular period, the menopause and perimenopausal period, that the risk of heart attacks and strokes is particularly high amongst women. And that's why it's very important. So I always tell my female patients to be very wary when you're reaching menopause. And normally you can actually tell when they come to the clinic, you know, all of a sudden the blood pressure and cholesterol levels starts to shoot up. And you know that they're actually nearing their menopausal period. So that's why it's very important to get them checked regularly.
Doctor, is heart disease genetic? Is it some hereditary? Like, do we get this from our genes and our family history? Does that matter?
Yes, it's very much so, actually. In fact, it's one of the things we always ask our patients, whether or not they have any history of heart disease in the family. And it is particularly stronger if your parent who happens to be the mum who's got the heart disease.
Oh, it makes a difference.
Yes, the genetic transmission appears to be stronger.
Okay.
Therefore, if you have a parent or parents with heart disease, and the parent happens to be a mum who's got the heart disease, then you have to be very careful. And in those patients, I always ask them to go for screening earlier.
Okay, okay. Are there areas that we don't know? What do we know about what we don't know about heart disease? I wonder whether that makes sense. Are there any areas that we still don't understand about heart disease that we're still researching, or we still need to learn more, particularly about how it affects women and how women present with the disease? Well,
I think there's certain things about heart disease which is perhaps peculiar. For example, some women can have heart disease, heart attacks, a full-blown heart attack, and yet have no obstruction in their coronary arteries. We do know that as well, and this is perhaps, it is thought that it's due to the disease of the smaller vessels in the coronary vasculature and in the coronary tree that you can't see on when we do angiograms. And but this research is still ongoing with how to detect this class of patients. And also now I think there's research also ongoing trying to detect earlier whether or not you have a genetic tendency to actually have heart disease, genetic screening, for example. But that's still very much experimental in most places, so it's still not recommended as a mainstream investigation for now.
And I was reading that more and more, so heart disease is happening to younger adults more and more often. So you talked about menopause and heart health, but are you seeing this happen in younger adults, younger women?
Yes, I think that's true. I do see it in younger people, and it's true to say younger and younger people. And I think one of the factors for this is perhaps stress of life, smoking, which is getting to be more, more apparent in younger women, alcohol
and
excess.
That includes vaping as well?
Yes, exactly. Okay. Yeah, and sometimes when the unhealthy lifestyles also gives rise to unhealthy diet as well. So that obviously are factors which contribute earlier presentation of heart disease in women.
Right. Let's talk a little bit about raising that awareness. So you talked about having specific kind of conferences and symposiums to teach cardiologists, younger cardiologists, about raising awareness, particularly about how this affects women. But what about patients advocating for themselves, for their own heart health? How, what would you say are the level of awareness currently, and how do we raise it?
Well, good question, Melissa. There was a survey done about a few years ago, and they showed that 87% of women around the world, when asked what is the biggest killer for women, they almost all of them said cancers.
Yeah, breast cancer or something. Yeah, that's the thing that comes to our mind, right?
Yes, exactly. So it was only about in the early 1990s that when they actually look at the data, of the real world data, looking at women and heart disease, only then they realized that actually more women die from heart disease. And before that, they were not even aware of it. So that's why we're trying to increase this awareness, as you very correctly pointed out, by having public forums, having talk shows like this, and teaching the public, to be aware, for your mums, for your wives, for your sisters, any of those symptoms that you think is not right, especially if you have risk factors, that should trigger early screening.
Yeah. For me personally, when I think about a heart attack, for example, what's been kind of portrayed in popular media has always been pain in the left hand, right? And we always assume, oh, if it's not pain in the left hand, that's not really a heart attack. Yeah,
well, yes and no.
Okay, all right, tell me.
Okay, now typically, the pain that's described by of a heart attack patient is a heavy sensation on the chest. Okay. It can be either right or left, usually central. Okay, and then patients normally say they can't breathe, and they start to have cold sweats, nausea and vomiting, and the pain usually radiates to the left arm. It can also radiate to the right arm, sometimes both arms as well. And so the character of the pain is very important. In women, however, they don't normally get chest pain. They can get chest pain, but normally the pain is atypical, like I mentioned earlier. They can get pain in the jaw. In fact, I had one patient who actually presented to her dentist with toothache.
Oh, it was a toothache?
Yes.
But it was actually heart disease?
Yes. Oh. Luckily, the dentist, I must say credit to the dentist, she was very switched on, told her there's nothing wrong with your teeth, you better go to the hospital, and she came to us and was a full-blown heart attack, so we took her to the cath lab immediately and did the angioplasty for her. She's fine now, and the toothache disappeared.
Right.
Yeah, and the patient presented with epigastric pain in the tummy, and she was told to have gastritis. It didn't work with the anti-gastritis medications given to her by the GP, and she came to us and she was having a heart attack. So that's why it's very important to know this symptoms, the variability in the symptoms.
Right.
So, but the risk factors are always important. It gives you a clue. So it lowers your threshold to investigate the patient if you think that the patient has got full-blown risk factors like hypertension, diabetes, raised cholesterol, a strong family history, people who smoke excessively or drink excessively, and overweight. And a stressful lifestyle as well. We now know that people who don't sleep as well and have very stressful lifestyles actually do have increased risk of cardiovascular disease.
Okay, so you can kind of do a personal audit of your lifestyle and see what risk factors you have. You mentioned sleep, doctor. I find that interesting. Sleep is important for heart health?
Mm-hmm. In fact, there's a very big thing now called the sleep hygiene in cardiovascular medicine. It is, we've often said, if you don't have enough sleep, it's not good for you. But actually, it's been proven that if you have less than 4 hours of REM sleep, rapid eye movement sleep, that means deep sleep.
Deep sleep, okay.
That is associated with increased risk of cardiovascular disease. And the theory behind it is that when you don't have enough sleep, your stress hormones are kept elevated, your cortisol, your adrenaline, your noradrenaline, and these stress hormones are not good for you. That means you're actually driving them up, for longer than they should be, and that increases all the consequences of atherosclerosis, stiffening of the arteries, and the problems that comes with it, heart attacks and strokes.
Yeah, it seems to me modern living, particularly modern urban living, comes with a lack of sleep hygiene. I mean, particularly late in recent years, and I do wonder whether we recognize as people how much that impacts our health.
Yes, that's true. And it's also notable that people who don't have enough sleep tend to have higher blood pressures for that very reason. And we do know...
It cascades, it
yes,
rolls, yeah.
Exactly, it does. And we do know that hypertension is singularly the strongest single risk factor for heart attacks and strokes. So it becomes a downward spiral. You don't have enough sleep, your blood pressure goes up, and people try to mood eat to keep them awake, so...
That's true.
Yeah.
That's very true. It is a vicious cycle.
Yeah, it is, very much so.
What would you say to your patients if they find themselves in that cycle? What advice would you give them to help them break out of it and reduce their risk of heart disease?
Well, I think if they think they've got those risk factors, the first thing to do is have a chat with themselves, and try to break the cycle, So try to sleep early, exercise at least 30 minutes a day, 5 days a week. That's what's actually recommended to reduce cardiovascular risk. Get yourself seen by a doctor to have your blood stand, to screen yourself for hypertension, diabetes, cholesterol, and try to stop smoking. Very important. Cessation of smoking has been shown to reduce the risk of cardiovascular disease. And obviously alcohol excess. Last time, previously it was thought you can drink a bit of alcohol, but 1-2 units a day, that's fine. But now the pendulum has swung the other way. In fact, it's been proven now that any amount of alcohol is detrimental. Okay. So it's best to stay teetotal. I.e. no alcohol at all. Okay.
We often think about, those are really great practical advice for someone who wants to reduce their risk. But if we think about it from more than just the individual, the onus on the individual, how do we think about it from a maybe public health perspective? As the #1 killer of women, that seems to me that it requires more of a concerted effort to address this. How do we think about it in terms of policies for prevention of heart disease, for interventions before we get to the point where we're dealing with the disease at a later stage?
Well, I think health talks are very important. It's also very important as well for medical teams to actually go down to the public, and try to create awareness by having health talks in villages or in small towns, just so that they are aware. And people who live in Klang Valley, obviously they are well exposed to all this. But the people on the ground, the people in the village, they might not be as well aware, and they might not be exposed to internet information as well. So it's very important to do that. Okay. I think the government has a role to play in that, by sending these medical teams to these places.
So this would be considered a non-communicable disease, is that right?
Heart disease?
Heart disease.
Yes.
Yes, okay. So prevention, we should be looking at it in terms of prevention and, accessibility to knowledge. All right. Coming back to our conversation about the field of cardiology, and in your role as clinical lead of cardiology services at Prince Court Medical, where do you see your role in trying to correct the gender imbalance and ensure that there is more diversity, gender diversity within amongst cardiologists? How do you encourage more women to take up this specialty?
Well, I think it's important to lead by example. and senior cardiologists, men and female, male and female cardiologists, to lead by example, and to show that it's very important to show that the lack of gender bias is very important for the public and also for patients at large. And it's very important as well, to have this mentorship, to encourage young cardiologists, to come forth, and if they have any issues, to be able to sit down with them and try to sort out the practical issues that they might be facing, and to give them support, as they go through their training, because the training of a cardiologist takes many years.
Did you have a mentor yourself?
Well, I suppose many mentors.
Okay, all right. They came in many forms.
Yeah,
okay.
They came in many forms. Yeah, that's true. And as you go from your journey as a junior doctor, and as a senior registrar, and then as a junior consultant, and a senior consultant, there are many mentors along the way, and we learn along the way. And I must say, all my mentors are men. Oh,
well, that's good. Then at least they're helping you along, but let's open more doors for women to be cardiologists. You talked a little bit about the tough training. Why is it so tough to train to become a cardiologist?
Well, cardiology is an emergency, very much an emergency discipline. It's very high octane. Very much.
That's a good way of describing it, high octane.
Yeah, and because you can't say when the patient's having chest pain, you can't tell the patient, I'll see you in the clinic tomorrow.
Right. Everything is acute, it's urgent, right?
Exactly. Yeah. And cardiology epitomizes that, So and because of that, you literally, when the patient comes with chest pain, we actually have to see the patient within minutes and start treatment within minutes, and therefore, to stabilize the patient sometimes takes hours, and therefore it takes long, the treating the patient, waiting for the patient to stabilize takes a long time. And when you're training, you're usually the infantry on the ground, so you have to see to all that. So that's why, the late nights, long hours sometimes take a toll on family lives. I've had colleagues who went through difficulties, and that's why it's very important to have good mentorship, and this is what I was referring to, so they can sit down and try to sort out, help sort out problems with them.
So I have to ask Dr. Norazlina, how did you beat the odds and to become the clinical lead of cardiology services? What strategies did you use? What helped you succeed when in a male-dominated field?
Well, I think I've always told myself, because I was so keen on doing cardiology, I was willing to do anything. Okay. So I've always told myself to do it, I have to work harder in order to show that I'm an equal. And I think that has really helped me. So, and to be willing to take on responsibilities, to say, if somebody to say you jump, you ask how high. You don't say, oh, can I jump? Can I not jump now? You say how high. So that I think that is how you push yourself through, to the ranks. Until your male colleagues accept you as their equal, and hopefully, then go on from there.
And you're seeing more people in the field get involved or interested, get younger doctors to be interested in a career in cardiology?
Yes, and I'm pleased to note that when I go for the national symposiums or meetings, cardiology meetings internationally, I'm happy to see that more and more female doctors, in training to become cardiology. And in fact, we now in most countries now worldwide, they actually have a group of women in cardiology, dedicated conference sessions for women in cardiology, just for that, to encourage young cardiologists, young female cardiologists to join in the team and listen to the problems they have and how to give support and bring each other up, in order to create this bigger number of female cardiologists.
You need critical mass to change the cultural norms. I want to thank you so much for being on the show today, but in the minute or so that we have left, could you share your takeaway message with the audience? People watching tonight who might be learning about heart health risk factors for the first time, or young women who are thinking about career in medicine, should they be considering cardiology? What would be your final message tonight?
Well, I think for those of you who are really interested in doing cardiology, I would say just go for it. You know, it might be long, it might be hard, it might be strenuous, but it is worth it at the end. And for patients who, you know, for those women patients or those ladies outside who might have problems or think they might have heart disease, always, you know, get medical help, because you never know, you also might be at risk.
Wonderful message. Thank you so much for speaking with me. I appreciate your time.
Thank you for having me.
That's all we have for you on this episode of The Future is Female. I'm Melisa Idris, signing off for the evening. Thank you so much for watching, and good night.